Hello and welcome to Lecture 4. So, we began the lecture last Saturday looking at the future outlook of community pharmacy, and what we opened up the discussion about was advocacy. And so, I'm not going to go back in this taped lecture to talk about that since we discussed it at the very end of Saturday's lectures. But remember, one of the things we talked about last week when we talked about PBMs, we talked about, insurances, we talked about how community pharmacy does currently bring in revenue and stay in business, that we're heavily dependent upon product for reimbursement. And so there's many challenges going on in community pharmacy today. We talked about the importance that for a pharmacy to remain in business and profitable, to be able to cover operating cost, that the average prescription dispensed needs to be at least 10.55, and sometimes with today's inflation, since that study in 2015, probably close to 12 or 13. We talked about the challenges to how overcome this. We need to be fighting, talking to our legislators, talking to both state and national legislators on the importance of why we need to pay pharmacy to protect patients and patient safety. So we need to talk about preserved product reimbursement. We need to work on making sure pharmacies can take care of the patients in their community. But what I'm going to talk about the remaining of this lecture is how community pharmacy is changing. It is actually getting able to work with other healthcare professionals and to be reimbursed differently. And so I already talked about your assignment on Saturday about advocacy. If you have any questions, please email me. But let's begin the last part of this lecture. The future of community pharmacy is good. There are a lot of different opportunities, and we're going to talk about those opportunities in these following slides. Currently, right now, the way pharmacies make money, as I said, is it relies heavily on prescription sales and over the counter for, non-prescription needed medicines for front end sales. But where community pharmacy is beginning to evolve, and we saw this over the last 10 to probably 15 years with immunizations, that pharmacists can actually administer a shot to a patient, depending upon state law, and you can not only just get reimbursed for the product, but you get reimbursed for your clinical service of administering that medication. And so the immunizations has grown to be part of, the revenue that is generated in a community pharmacy. But what we're seeing, and we've seen slow growth of other clinical services, that instead of being paid for product, you're paid for your knowledge and the service you bring. We see that with medication therapy management. We see that with disease state management, such as diabetes education. And we also see that in other different types of programs, and I'll explain some of those there. The performance star measures I talked about in Lecture 3, and those are tied to prescription sales, but those performance measures also need clinical intervention. So adherence programs, adherence packaging, those are things that pharmacists are working with patients from a clinical perspective. And there are ways in the future, and even now, for pharmacists to be paid by physicians' offices to help with adherence. I mentioned before that a good pharmacist, as long as you're providing value in the next 10 years in healthcare, you will be fine. And so as you go through your training in pharmacy school, learning the knowledge about the medications, how they interact with, the disease states that they're intended to help, and your skills of communication, not only with the patient, but with other healthcare professionals, will bring great value to you. And, people will be seeking pharmacists with those skills in now and in the future. Pharmacy itself, as I said before, that only 10 to 15% of all healthcare spending is done by the prescription side, whereas the most expensive thing in healthcare is hospitalizations and ER visits. Community pharmacy and community pharmacy services in helping with adherence, avoiding medications that could cause adverse drug reactions, identifying medications that are more effective for certain disease states can overall help reduce healthcare spending and improve quality of life of patients. So the biggest impact community pharmacy services can do is, as I said, there's numerous studies that have shown that they can help reduce inpatient hospital admissions, prevent ER visits, and also prevent readmissions. Traditionally, we talked about on Saturday all the different tasks that go on in a community pharmacy, but those skills that you do can also evolve in doing other types of services. So, let us talk about what medication therapy management. Medication therapy management is different than counseling. Medication therapy management is a patient-centered assessment. It is not just counseling on one individual drug. It's looking at the full medication regimen and how that relates to the patient's goals, and the patient's disease states. And the goal of medication therapy management services is to make sure the patient is taking the best medications to either prevent, treat, or slow the progression of their disease state. The goal is that this medication therapy management service helps us collaborate better with the patient to meet their goals and collaborate with other healthcare professionals to meet their goals. The goal of medication therapy management allows us to communicate in that collaboration and empower patients to have better control of their health. This picture here shows all the different things that a pharmacist would be doing daily in a community pharmacy, such as identifying drugs that might be the dose is too high or too low, identifying patient issues such as side effects, adherence issues, identifying maybe in talking to the patient, maybe this drug is not working or not effective. In all those tasks, the pharmacist is either contacting the physician or other healthcare professionals to improve outcomes. And community pharmacists every day in their practice are doing this. This sheet comes from a study myself and Dr. McConaughey, who's one of the other faculty at Duquesne, where we actually had pharmacists in the community, both at the chain and in the independent stores, track their interventions. And we tracked them for 3 months. And we found that the 2 pharmacists that participated in the study both almost did 1,000 interventions over those 3 months. The purpose and goal of this is that's what medication therapy management is identifying problems and improving upon them. And so community pharmacists every day in front of their computer terminals are dealing with drug-related problems. And so medication therapy management services was developed by Medicare D law, but medication therapy management has seen other laws occur. Several states have what's called collaborative drug therapy management, which allows pharmacists to be empowered by physicians to do clinical services, and different care models such as account care organizations, the personal medical home model. Those are all looking at how can pharmacy improve outcomes for them. So the pharmacist's role is shifting from that distribution role that we've been so heavily dependent upon to a more clinical role on the outpatient side. Because the overall medication therapy management services of why they were implemented and passed into law all the way back in the initial bill in 2003 was if somebody effectively takes their medications appropriately, we can reduce Medicare Part A dollars. So medication therapy management initially was a law passed by Medicare D intended to take care of Medicare patients to make sure their overall medication therapy was being used appropriately. And so what the law requires is patients that have multiple disease states patients that have high drug cost, that they should have their medication reviewed at least annually. And some patients, specifically for star rating drugs, where adherence or not using drugs appropriately, for example, diabetics would benefit from cholesterol medications, that these are looked at quarterly. So MTM services by the Medicare D law require med reviews at least done yearly and target med reviews. The overall goal, as I said earlier, is medication therapy management services are patient-centered. They're asking pharmacists to do a full medication regimen, not just looking at individual medications, with the goal of optimizing medication use. When MTM first started, it was a slow process. And some of the reasons why it was a slow process was pharmacists who had pushed to have this law passed were already practicing in ambulatory care centers, nursing homes, and inpatient hospital, and knew the value of what pharmacists reviewing med regimens and collaborating with healthcare professionals can bring. The problem, though, when this was passed, was we didn't know, or at least Medicare didn't know, where to put this. And so they put the responsibility of MTM on the Medicare D plan, which a lot of times was run by the pharmacy benefit manager or a healthcare plan. And when they passed this, they also did not have any additional funding for it. And so pretty much they put the responsibility on the healthcare plan or the PBM to do this without additional funding. So for years, this MTM really resided more by just telephone calls from a call center in the PBM or health plan. But what's evolved over the years is a process. When you look at any provider, and I talked about this on Saturday, that, for example, when a physician sees a patient, they start from head to toe to do an assessment. When a dentist sees a patient, they start on the first tooth. When a pharmacist sees a patient to do a medication therapy management review, what do we do first? We interview the patient. We collect information. We find out things such as how they take the medication, their understanding of what the medication is for. We evaluate and collect different labs to assess outcomes of the medications or certain tests such as blood pressure, heart rate. We also then collect that information to assess things such as adherence, any possible adverse drug reactions occurring. And once we collect that information, we assess to see if there is any identified drug-related problems. Once we collect and assess, we plan. We find out what is the best way to optimize this patient's medication therapy. And then we'll implement it by either sometimes having to educate the patient, but also contacting other healthcare professionals if we need to make changes in their medication regimen. And so this pharmacist-patient process of care that has been developed over the last several years has allowed pharmacists, especially in the community, to standardize what MTM is. And also, this is kind of where the push to get provider status has occurred. The other thing that's occurred over the years is Medicare has defined what are the key elements that have to be done in an MTM. So there's a process too under Medicare. The med review, which is the collection phase. The patients themselves will receive, once you do an MTM, an updated medication record of what medications they're on and when they should take them appropriately. The other thing is an action plan. The patient will get information of what they need to do to help self-manage their medications. The pharmacist will do interventions and referrals when they need to collaborate and communicate with other healthcare professionals to recommend changes, especially if there's medication-related problems. And then it's required that there's a documentation to show that this service was done and so that it can be billed. So it's required as of January 2013 in the Medicare law was that MTMs under Medicare have to be performed at least annually, They can either be a face-to-face visit or a phone call. And once they're completed, the patient will get a cover letter explaining what happened. They'll get an action plan of anything they may need to do to help improve their medication regimen and an updated medication med list of when they should take things. This standardization has also allowed us to start billing for MTM. This link on the pstac.org is a link to teach you how to bill for MTM services. One of the other things is we know that physicians get NPI numbers, pharmacies themselves get NPI numbers, but there is a big push for pharmacists to get provider status. And we've seen this at the state level. But I encourage everybody, when you graduate, this link, you can actually get your own NPI number. Currently, right now, because we are not providers, we can't bill directly. Only the pharmacy can bill directly. But an NPI number is a way that in the future, you'll be able to bill for services. And for states that pharmacists have got provider status, such as the state of Washington, the state of California, they are using the NPI number for billing. The other thing when MTM was developed was this is a medical service, not a drug distribution service. And because this is a medical benefit service, it needed to follow what all Medicare clinical services require, and that is a CPT code. CPT code stands for the current procedural terminology, and CPT codes are the accepted ways to identify what clinical services were done by a healthcare professional. Physicians, nurse practitioners, physician assistants use CPT codes every day when they see patients and what type of services they implement. The other thing that goes along in the billing is it usually has to be accompanied by an ICD code, which right now we're on ICD-10 version, and then an ICD code is a code that identifies what disease states the patient has. So if you were doing an MTM service, we have 3 codes, and these 3 codes are the following. If I was initially seeing the patient, my code would be 99605. And if this visit was like 30 minutes and I had an additional 15 minutes, I would bill 99605 plus 99607. If this was a follow-up visit, I would bill 99606 plus 99607. And these codes, based upon what contracts you have, are tied to a dollar value of what you're going to be reimbursed. The average reimbursement for an MTM ranges from $60 to $70 for a comprehensive review, which should last no more than 20 to 30 minutes. So when are these MTM CPT codes used? According to the manual, they are used when you do see a patient. They include that you have done the following services. You've done a patient history review, you've updated their medication profile, and you've made recommendations to help improve health outcomes and treatments for adherence. There are several different companies pharmacies contract with to be able to do MTMs. Marixa, which is one of the bigger companies, will contract directly with the PBMs and health plans and then contract with the pharmacies, and you use actually a web-based software system to bill for these services. Outcomes is another company which is now owned by Cardinal Wholesaler, and Outcomes also does the exact same thing. They're a web-based documentation system that a pharmacy signs up and signs contracts with Outcomes or Marixa, and they directly make contracts with Medicare D, health plans, and PBMs. I'm going to talk about there's other people that are out there, and we're going to talk about state clinical networks in the next couple slides. So what's on the horizon for Pennsylvania and for the entire country? Well, one of the big pushes over the last couple years, and it's been a slow push, is to get provider status. And what provider status would mean is that the pharmacist, not the pharmacy, would be recognized as a healthcare clinical service provider. And then we would be able to, with this provider status, bill for clinical services, in any type of setting, whether we're working in a doctor's office, a pharmacy, or in an outpatient hospital setting. Initially, the provider status bills that have been introduced over the last couple years, both in the House and Senate here in the United States, have focused initially on just getting provider status in medically underserved areas. Here in the United States, we have a big crisis happening. We have a very big shortage of primary care physicians. And because of this, we feel that this is where pharmacy would be benefit the most initially. One of the reasons why we're not going for full provider status yet is we want to kind of meet people halfway. That let us service those underserved areas and show the value that pharmacists can bring. And then once we show that value, that provider status possibly could be expanded. Nurse practitioners, when they were going for provider status years ago, went the same route. Now, some states have developed their own provider status. As I said, the state of Washington, pharmacists can do pharmacy services where they bill both Medicaid and commercial insurances, and California right now has provider status to bill Medicaid. But what's happening here in the state of Pennsylvania? Well, if we would get that national provider status, as I mentioned, if you take a look in the counties where the dark green is, that would be the only places a pharmacist could practice as a federal provider. But what our state has been doing, and we've been seeing this on a national trend, is to develop what's called state MTM networks. And what this is developing a network of pharmacists who want to provide MTM services. And if we have enough people that are wanting to provide MTM services, we can then actually go to payers such as health plans, PBMs, and mainly health plans, not PBMs, I take that back, health plans, and not on the pharmacy side, but on the medical benefit side, that want to contract with pharmacists to be able to provide clinical services. NCPA, which stands for the National Community Pharmacy Association and represents independent pharmacy, has launched over the last couple years a national network, which is called the Community Pharmacy Enhanced Service Network. This network originally originated from North Carolina, and North Carolina was one of the very first state networks to be developed. North Carolina developed their state network with a Center for Medicare and Medicaid Service innovative grant, and what they were able to show in this grant that having a state network, pharmacists doing MTM type of services with patients and identifying drug-related problems decreased healthcare dollars in hospitalizations and ER visits. So this CPSN would represent like the national to get national contracts, and they would partner with state networks to be able to help states have their own networks. Currently, right now, Pennsylvania does have a network. It's called the Pennsylvania Pharmacy Care Network. And actually, when you are in your second to last year of pharmacy school here at Duquesne, you'll be actually able to go through the training program to be a Pennsylvania Pharmacist Care Network provider. The goal of this network was, and it was developed through different leaders and all 7 schools of pharmacy and our state pharmacy association. And this network is to develop a network of professional pharmacists who want to provide MTM-like services to help improve positive patient health outcomes. The PPCN goes beyond just MTM, is actually contracting with non-Medicare health plans, both Medicaid and commercial. And the goal of pharmacists that are in this network would be to get contracts with these health plans, and they would see patients to help take care of medication-related problems, such as, is this the right drug for them with their disease? Is this drug effective for them? Is it safe for them? Prevent adverse drug reactions? And also, are the patients adherent to them? And people that belong to this network would be able to bill for these services. Currently, right now, the PPCN actually has one contract, and they have several contracts that are in there already in work. Currently, all my pharmacies are part of the PPCN, and we actually, through this contract, see patients, and we can see them one time to do a complete medication review, which we get paid X amount of dollars, and then we can do 6 follow-up follow-ups throughout the year, which we get paid for. And we get paid for seeing the patient and doing clinical services, making recommendations, providing education. Other people that are interested in this type of model are account care organizations and the medical home model. They are currently have across the country hired pharmacists to provide clinical services because they know the value that pharmacists can do in helping improve adherence, making recommending effective medications, and reducing healthcare dollars. There was a paper published all the way back in 2010 in Health Affairs that showed why pharmacists should belong in the medical home model. One of the other things that states have been doing over the last several years is passing laws within their state pharmacy act allowing pharmacists to partner with physicians under collaborative drug therapy management. Here in the state of Pennsylvania, we actually passed the law twice. We passed the law once in the early 2000s to allow collaborative management to occur in the institutional setting, such as hospitals and nursing homes. And in 2010, we passed the ability to do collaborative practice in the outpatient setting. What actually is collaborative practice? Well, collaborative practice is a pharmacist and a physician working together where the physician gives authority to the pharmacist. There are currently 46 states in the U.S. who have authorized collaborative drug therapy management agreements between pharmacists and physicians. Each state may differ in what the pharmacist can do, but using the process of MTM will help drive the success of these programs. So basically, a collaborative practice agreement is a clinical service agreement between one or more physicians and a pharmacist, and is a defined protocol the physician that can delegate authority to pharmacists to be able to do certain tasks. This has to usually be approved by either a medical committee or a state board of pharmacy. Here in the state of Pennsylvania, it has to be the state board of pharmacy. What are these collaborative drug therapy management tasks? They include performing patient assessments, ordering and evaluating drug therapy related tests, selecting, initiating, monitoring, continuing, and adjusting drug regimens, assessing patients' response to therapy, counseling and educating a patient on medications, and also administering medications. Technically, for a pharmacy to do immunizations, they have to have a collaborative practice, and that is what most pharmacies here in the state of Pennsylvania have to be able to administer immunizations. Why would physicians want to partner with pharmacists? Well, physicians, just like pharmacy contracts and health plans, are being graded, and their reimbursement of how they will be paid from Medicare will be based on outcomes, how well their patients do. And because, as I said earlier, patients rely heavily on medications to improve outcomes, partnering with pharmacists makes total sense. There is a way currently right now with collaborative practice that a physician could bill for the pharmacist service, and this is what's known as incident to. So the physician can, by giving that task to the pharmacist, there are certain services the pharmacist could do that the physician could bill. These are just a listing of different codes that the pharmacist can do. Pharmacists can be involved in doing diabetes self-management training, where the pharmacist helps the physician do diabetes education. Obviously, there's traditional MTM. There are ways the physician can have the patients do med reviews, and also another service which is called transitional care, where when a patient is discharged from the hospital, somebody calls the patient within 48 hours to make sure that there's no problems with their medications. Another is annual wellness visits, where you overlook the patient and make sure that there's any preventative health services. And a newer one where pharmacists are getting involved is called chronic care management. All of these in the Pharmacy Practice 6 course we'll go into more detail, but my goal today's lecture is just to show you what the future looks like on how pharmacists could get paid for doing clinical services. The challenge that we have in community pharmacy, though, is we've worked out workflows on how we fill prescriptions, whether it's getting, e-prescribing or somebody dialing in their refills, using technology to bill the claims and robots to help fill the prescriptions. But the challenge that we have here in community pharmacy, and we don't have a perfect answer yet, is how can we incorporate these clinical services in our normal workflow? So that is just a snapshot of the future of community pharmacy, and I'll be providing the study guide of what key things I would like you to know from this. Also, to remember, your take-home class participation assignment is posted on Blackboard and is due on November 27th. Thank you very much, and have a good week.